Good morning, sir.
കേൾക്കാവോ? ബൈ ബൈ.
Kumar, how are you?
ശരി അപ്പോ ഓക്കെ. So good afternoon. Good afternoon, sir.
Yeah, how are you doing?
Yes, sir.
Our plan, right?
Yeah.
Yeah, we'll start.
Yeah, we have been told about that, right? You have been told, right, Kumar?
Yeah.
Okay. I was looking for Jerry. I missed him.
Yeah.
I'm here, sir.
Okay, great.
This okay, no? This mask is okay. ഇങ്ങനെ വെച്ചാൽ മാറ്റണേ മാറ്റാം, പക്ഷെ വേറൊന്ന് വേണം ഇത് കഴിഞ്ഞിട്ട്.
പോലെയാ.
Can you please go on mute?
Yeah, sir. You know,
we are already here.
We are here, sir. We cannot have the video.
Yes, you don't have to give video, but you have to place yourself on mute, please.
Okay.
I'm not in the video?
You are there.
You're very much there.
You are in video, sir. You are in video.
Very much there.
You, Dr. Rajalakshmi and Kumar sir in the video.
Sunil.
Yes, sir.
Can you see me?
Yes, he can see you.
Yeah.
Okay, good.
Could I please request that everyone mute? If I could have everyone press on mute, please.
അതെടുത്ത് ചെവി വയ്ക്കണം. Zoom out.
You're logged on, but you're already on.
Can you hear me?
I can hear you. If you can just focus the camera towards your center a little bit, please.
How is it now?
Yeah, that's good.
That's okay?
Yeah, so we'll give it a few
I
more
think,
minutes. It's just approaching time. So we'll give it a few more minutes before we get started.
Sure.
Sorry, you were
can-
going to
you can-
say something?
No, you can hear me well?
I can hear you clearly.
Okay.
Hi.
What do you want? Or start video on?
കുറച്ചിടയ്ക്ക് തന്നാൽ മതി.
കേൾക്കാവുന്നൊക്കെ. Can you hear me? Huh? I think ask her, otherwise.
We can hear you clearly.
Yeah, thank you.
Questions, no? The chat questions we'll get now.
Yeah.
He'll ask you and you can answer.
Yeah, but that is after the after it will be over by about 15-20 minutes, and then we'll open up for the question answer session. That's what Rajalakshmi also says.
So for everyone who's joined, a couple of requests. I'll mention this again. If we could have people be on mute, number one. Number two, for the non-participants, if you could also switch your video off. And number three, if you could make sure that your display, your name is there in the display name, so we know just for concerns of security, we know who is on.
Is it okay? I changed the microphone.
Yeah, that's fine. Yeah, it's good. Okay, I think, shall we go ahead and get started?
Sunil is there.
So Sunil, Dr. Kumar, Dr. Rajalakshmi, are we ready? All right, good afternoon, everyone. My name is Sharif Sahadullah. I'm going to be your moderator for this webinar session on the psychological aspects of the COVID virus on healthcare workers. This is the first time I've been a moderator on an online forum, but the situation has necessitated that we use these emerging technologies to connect with one another. So I thank you for all joining in this forum. I think before we get started, there are a few housekeeping points that I'd just like to mention. Number one, for security reasons, I would ask that everyone has logged in with their name on the screen as your login. Secondly, I would ask that everyone be placed on mute. We're using a Zoom platform. The mute button is in different places depending on whether you're using an iPad or a screen. On my iPad, it's on the top right. I think in the computer, it's on the left bottom. But please press mute. And I would also request, so it's not a distraction for the speakers, if those who are not participating in the conference, the non-speakers, if you could also put your video off. You'll still have the ability to see us, but if you could just put your video off, that will be helpful. At the end of the session, or even in between, you will have the opportunity to ask questions. You can do so by the chat function, and you can submit your question that way. Please do not unmute yourself to ask a question. If you do unmute yourself, this is also being controlled by the IT department, and they will put you back on mute. But if you'd like to ask a question, excuse me, could we please have everyone on mute, please? So if you'd like to ask a question, please submit it through the chat. And there's a team that will review all of the questions and present those questions to Dr. Kumar and Dr. Rajalakshmi, our speakers for the day. And we may not be able to get to all of the questions, but I'm sure there'll be certain common themes in the questions, and we'll try to answer those questions as best we can. So we'll get started shortly. I'd like to turn it over to our chairman, Dr. Sahadullah, to say a few words.
Hi, good afternoon to everyone. Thank you, Sharif, to starting it. Can you hear me?
Yes, please go ahead.
Yeah. It is nice to, I can see only a few of you, so it's nice to have all of you for this webinar. I would like to welcome each one of you, and I know that because of the restrictions, I couldn't travel or meet you in person for the last 4 months. I would also like to welcome Dr. Kumar, who is well-known psychiatrist as well as the head of the psychiatric division of KIMS at Trivandrum, and Dr. Rajalakshmi, who is the head of the infectious disease department in KIMS at Trivandrum. And the ID department has become into much prominence during this crisis. Just a few words. I think we are passing through challenging times, and I think a lot of the situation is not just going away. It is lingering on, some of it, but some of the places is getting better. The global situation is very and not very encouraging so far. In Kerala, it's slightly better, but I'm sure all the countries hopefully, inshallah, will get better. It is the various aspects of in anxiety or rather uncertainty is causing us a lot of psychological impacts, especially not only the uncertainty of the disease, uncertainty of the treatment, and perhaps also the social isolation of lockdown. So this going to be more of an interactive session after Dr. Kumar and Dr. Rajalakshmi talks. And I think, Sharif, you will be introducing them a little bit.
Yes.
Yeah.
Yes.
Okay. And so I welcome to all of you and make it a very interactive session. And I also want to mention that some of our members of staff in GCC have turned positive in the testing, and but I'm glad to note that all of you are recovering, and all our support is there, and all our prayers are with all the frontline healthcare people. Thank you very much, and please go ahead, Sharif, with the session. Thank you.
Thank you. Yeah, I want to just mention that this webinar is being broadcast over 6 countries, and I think that's clearly a strength of the organization, our diversity, yet we've come together for a common cause and common purpose. First of all, let me say that I hope all of you and your families are keeping safe and healthy during this unprecedented time in our history. These are clearly very challenging times, and the way we live has changed significantly over the last several weeks. These dramatic changes are potentially significant stressors in our lives. In the healthcare, we've been focused a lot lately on the medical aspects of the disease, how we can prevent it, how we can treat it, what is safe in this situation to do in the hospital or not do, and so forth. However, the psychological aspects of this worldwide pandemic is often overlooked. As healthcare providers, often there's an increased level of stress because we're on the front lines of treating patients who may potentially have the disease. And how we're able to cope with these stressors can also have a significant impact on the care that we're able to provide. Over the last several weeks, I've been in touch with my former colleagues from the US, many of them who are in New York City and are battling COVID on the front lines. They are both physically and mentally exhausted with what they're seeing in their hospitals. And this exhaustion, be it mental or be it physical, can often lead to errors. And that's one thing that we want to try to avoid. So the session today is really how, as an organization, can we provide support for all of you, healthcare providers, who are on the front lines, potentially seeing the disease. So with us today, it's a pleasure to have Dr. Kumar. Dr. Kumar is an honorary senior consultant with the Department of Psychiatry and Behavioral Medicine at KIMS Hospital. His subspecialties include alcohol, tobacco, and drug addiction, depression counseling, psychological counseling, schizophrenia disorders, and psychometric testing. Today, he'll be elaborating on the psychological aspects of COVID-19. Also with us today are Dr. Rajalakshmi, who is the, as Chairman said, the chairperson of infectious disease and infection control at KIMS Hospital, hospitals across Kerala. She's a senior consultant of the infectious disease, and she has to her credit over 19 publications in international journals. She's also the recipient of the Infectious Disease Fellows Program Award. She's been an essential part of our COVID preparedness team. So I thank you both for joining us today. Scheduled to join us today was actually Dr. Arun. Dr. Arun is a urologist in Oman, at our hospital in Oman, who contracted COVID primarily through community spread and not directly related to patient care. And we had several people who contracted COVID and it came into the hospital setting. Fortunately, everyone is doing well. Dr. Arun is in the recovery phase, but still he's experiencing some difficulty breathing when he speaks for extensive periods of time, and coughing as a result of that. So he asked to be excused from today's session, but we hope to have him come on to future sessions to share his experiences in terms of the recovery from COVID. So unfortunately, he will not be joining us today. So with that, I'd like to turn it over to Dr. Kumar and Dr. Rajalakshmi to take the session forward. Just as a reminder, if I could just mention, please keep yourself on mute. If you do have questions, you can ask those questions through the chat, and the team in Trivandrum will process those questions and present them to our speakers today. So thank you, and I'll hand it over to both of you.
Sharif, can I just add one more thing, Sharif?
Yes, please.
Yeah. Dr. Kumar was the Director of Medical Education in the Medical College, Trivandrum, as well as he is a special member in the war room of COVID-19, Government of Kerala. So he is a member of so he is in the front line dealing with these problems. Anyway, thank you.
Sharif?
Yes, thank you. Please go ahead, Dr. Kumar.
Thank you, Chairperson Dr. Sharif. Thank you so much, our Chairman, Dr. Sagadullah, Dr. Rajalakshmi, my co-panelist, and friends. First of all, I should place on record the appreciation for our Chairman, Dr. Sagadullah, Dr. Sharif, and the management of KIMS for floating this webinar. I'm sure that this is a topic which has occupied and preoccupied the mind of healthcare professionals all over the world. And several weeks back, or maybe a couple of months back, when the problem started gathering momentum, there was a lot of concern, lot of apprehension, but there was also a lot of disbelief, because many people thought that this is all right over there. This is not going to hit us. And this is common because epidemics as well as wildfire, forest fire, they are almost similar because the efforts at extinguishing will not be convincing to people who are not directly at the receiving end. Till it comes to their midst, people have a disbelief. So that was the situation from where we started, and now I don't have to elaborate where exactly we have landed up now. Or we are trying to just to stabilize the problem with all the might, all the mechanisms that are in our possession all over the world. So my task here is to just to briefly present to you the psychological aspects, or rather the mental health impact of this epidemic. And then I would say rather to listen to you all with your perceptions, your experiences, and your suggestions as to how we can proceed. Because it is recognized that the healthcare professionals, the clinicians, the nurses, the paramedics, and the other health staff who are fighting this, they are prone to mental health impact in a significant way. As you know, disaster medicine has a considerable mental health impact. Coming to a bit of history, the whole thing started with World War I because the various impacts of the war victims, that was highlighted in a very, very significant way during the World War I. That was the beginning of this, what can be called as disaster mental health or disaster psychiatry. I'm not going into the details of it. Then we have the, of course, the terms were combat neurosis. Neurosis used in a very, very vague and very general way. But then natural disasters, quakes, then floods and tsunami, then famines, pestilence, then civil wars, and finally in 2001, as the new millennium rolled on, we have the World Trade Center of part of the terrorism. All these are the disaster, and there is a disaster medicine which has come in a very big way following the, as the 21st century was born after the World Trade Center disaster. Now coming to the epidemics, epidemic medical care has a number of features, and great epidemics, all the great epidemics in down the history, they are accompanied by lot of suffering, not only the physical suffering or the physical injury, but sordid descriptions of distress and agony. You can find in history, you can find in literature, you can find in all portals of human communication. And take it from me, for every physical harm or physical injury, there is at least 5 or 6 mental health harms or mental psychological harms. This is a simple formula. For every physical injury, there is at least 5 or 6 psychological harms, which people are subjected to. Now, coming to this century, we have the privilege or the rather the opportunity to get in touch with the many epidemics. SARS in 2003, then MERS in 2012, and Ebola in 2014 onwards. And there's a lot of literature that is coming about the mental health impact of this. As you know, in epidemics, the medicine or medical care of epidemics, there are various distinctions. For example, the evidence-based approach, which make us strong in the clinical front, is very often not possible because you don't have any evidences so far. The experience-based or empirical, as we say, that is also may not be there for all facets of clinical intervention because you don't have the experience. So that is where the epidemic medical care presents problems which are substantially different. There are no clear protocols. We are all comfortable when protocols are there in our management. Then heavy patient flow, restitution space and slot is not available. You have to recoup fast. You have to act fast. That is the epidemic medical care. Time, space, and resource constraints are a rule rather than exception when it comes to epidemic handling, epidemic medical care. The whole thing, when compared to intensive care in other planned settings, in elective settings, or even in the conventional emergency settings, here you find the situation is very nebulous, very much in flux, and maybe extremely labile. So it is like dancing on just on the tip of your toe on a fast rotating and fast moving or fast oscillating floor. That is what you do in epidemic medical care. So briefly, that is the task. Now, mental health impact, obviously in such a setting, would be more frequent. It would be more complex and more intractable. And the protocols are not there. They are not feasible because the epidemic itself keeps evolving and you have to adjust, attune, and accommodate many aspects of management. Then classically, it is an unfamiliar situation, unfamiliarity and uncertainty. And unfamiliarity regarding the infectivity, the personal risk involved, the risk to the family, and then various dilemmas in protocols, dilemmas in personal protection, whether this practice of protection is enough or not, we don't know. Then ethical dilemmas, prioritization of procedures and gadgets and facilities. That involves an ethical dilemma. Then even off duty when you go, you get a dilemma, whether I am sufficiently sanitized or not. Or do I have to do something more? So you can imagine the plight of a healthcare professional who has to do it in the epidemic management. So an unfamiliar enemy as our COVID is, and then an uncertain weapons and strategies. You can imagine what sort of a fight is happening in the healthcare front. In coming to COVID-19, the virus, the enemy is familiar to us only 4 to 6 months. It is still in the process of evolution, and virus behavior is not clear in many respects regarding incubation period, the asymptomatic cases, how to approach them, how to identify them, then individual relapse, whether infected person get a reinfection, then waxing and waning of the epidemic pattern. We don't know any, even now we don't know. Herd immunity, questions of herd immunity. Then post vulnerabilities, uncertain therapy, uncertain prophylactic practices. And we all have what is called a xenophobia. Xenophobia is the fear of the unfamiliar. And then questions of stigma, the ostracism, the exclusion, and then an internal stigma, what is called alienation. You feel you are stigmatized to some extent, being infected with COVID or being in contact. I think these are few things I thought I would put in the perspective. The disaster medicine, and then especially the epidemic medicine or epidemic medical care, both is fraught with a large spectrum of mental health implications, mental health impact, which I thought I would present. And I would rather, because in our institution itself, in the healthcare sectors, a KFA survey has been done by my colleague, Dr. Rajalakshmi. In fact, when this presentation was slated, I thought the best way to unroll it is to listen to Dr. Rajalakshmi, because most of it is the infective or ID department, their inputs into it. And in fact, she has collected the KAP survey, conducted a KAP survey on a large number of healthcare persons. And I request Dr. Rajalakshmi now to present it. Dr. Rajalakshmi, please.
Thank you, Dr. Kumar. I know that many of us, probably to some extent myself included, look at those numbers, and there are different websites in terms of infection rates across the world. And, a lot of us look at those numbers before we go to bed and when we wake up in the morning, and most of our discussions through the day are regarding COVID. And that itself is probably causing a significant anxiety amongst healthcare workers. And sometimes we also just need to separate ourselves from the discussions of COVID and try to get back to some semblance of normalcy. But we'll get to the questions and answers in a minute. I will turn it over to Dr. Rajalakshmi to take over from here.
Thank you, Dr. Sharif, for the introduction. And thank you all for joining in this webinar. Am I audible?
Yes.
Yes. Yeah, okay. So my sincere thanks to all the frontline workers, I should say all the consultants and the residents who have been in the front line in all the COVID isolation area so far in the last 2 months. And we know that our life was not so in December. In January, slowly we started to learn that there is a a problem coming up. And slowly our life or the normal activities were crept by COVID, and it peaked in March, and we still have a long way to go. So I should say that I learned a lot from residents' feedback, I should say, so far. And during the last 2 months, with feedback from consultants and residents, I could understand their concerns, their worry, and I should say maybe 20% may be a perception problem as well. So I should say there are real problems, there are perception problems, and both has to be dealt with. So I thought to handle it, first I should know what are the problems and where they're real and how to address. So that's when I thought I would circulate a KAP, Knowledge Attitude Practice questionnaire, and to get a feedback and assess the problems. And then we thought probably we should address them through some meeting, and there will be some scope for improvement. Some may be real, as I said. So we'll have some gaps which can be attended, and some may be perception which may need counseling. So that is my take, and that is when I started this KAP questionnaire. And again, I thank all of you who have participated in that and attempted those, because those feedbacks are important for making a difference and move on. So I will share a few slides that I have. Can you see them? Can you see the slides now?
Yes.
Yeah. Okay.
Please go ahead.
Okay. So what I did was I circulated a set of questionnaire for doctors as well as nurses. And I will just share a few questions that is pertaining to psychological aspects. problem in moving to the next slide.
The slides are not moving.
Yeah, I'll try that. Sir. Okay, can you just wait?
Perhaps you can just describe how you collected the data and then go ahead with the salient findings. If you do not want to worry about the slides. And then we can go ahead with the question answers. Perhaps.
I think we lost, did we lose Dr. Rajalakshmi? Sorry, 1 minute, folks. Just experiencing some technical difficulties. We'll try to reconnect here in just a minute. Dr. Rajalakshmi, you're on mute. Can you hear us? Are you still there? If not, Sunil, could you please call her? Dr. Kumar, I think you're trying to say something. Unfortunately, you're on mute as well. I think while we wait for Dr. Rajalakshmi, I'm going to hand it back over to Dr. Kumar. Dr. Kumar, if you want to add something more regarding the psychosocial aspects, and if Dr. Rajalakshmi is not able to join us, then we can move on to some of the questions as well. So I'll hand it back over to Dr. Kumar.
Yes, thank you, sir. Because I would briefly tell that there has been a substantial study on SARS 2003, a cross-sectional study and a 3-year follow-up study, which shows that the 10% of people, they have a very serious type of mental health impact among healthcare workers, and 15 to 38%, they had other type of psychological problems. And significantly, 60% of them recovered in three-year follow-up, but 40% continued to have residual mental health problems. This is a beautiful study. This is published in Canadian Journal of Psychiatry in 2009. Now, the factors which are sort of correlated with high mental health morbidity are high work exposure in the epidemic care. More hours and more number of days when exposed, proportionately mental health impact is high. Those who are subjected to quarantine, has a higher incidence. Death of dear people, that is the family members or dear ones, then prior life events, and high media exposure. This has come as robust correlations for mental health impact. And now in COVID-19, from Wuhan itself, some studies have come, not good quality studies, but more like preliminary, and they have shown that 48% of the healthcare workers have some sort of mental health impact or not. Now, manifestations of mental health impact are: one, emotional disorders like anxiety, depression, and agitation, irritability, and anger. And there's one particular syndrome that is described, what is called numbness. A person becomes frozen, almost freezed to inactivity. That is one of the things which have been described. Then cognitive deficits like lack of concentration and forgetfulness. Then what we call as post-traumatic stress disorders, and then depersonalization and dissociation reactions. Neglect, behavior problems like neglect of personal care, sleep disturbances, reduced appetite, loss of weight. Then the fifth sector. So we have mentioned emotional problems, cognitive problems, major syndromes, behavioral disturbances, and finally, escalation problems, means problems in actual execution of work, dereliction of duty, duty fault, absenteeism among the healthcare workers in epidemic care. Then disruptive behavior, even becoming aggressive and even putting a paper, a resignation or quitting. So these are all reported in the previous studies in relation to SARS, and you can expect them probably in exaggerated dose in the COVID care. Then I will just mention the management aspects. Conventional counseling, conventional psychotherapy is not appropriate here, because nothing is conventional in the medical care itself. So how can mental health care counseling alone be in conventional? It needs to be more flexible and semi or unstructured. Very often our techniques will have to be, and more operational than psychological. That is the reason why I thought Rajalakshmi should be there. It is not the psychological input which we are putting. It is the operational inputs, the system changes, system modification, system remediation, which is needed for many of them. In fact, what we are doing is not a psychotherapy or psychological counseling, what is now called as psychological first aid, PFA. This term came into circulation, came into currency following the World Trade Center disaster. It is not a substitute for clinical counseling or a psychotherapy. There's another term what we call as psychological immunization, so that people become resilient, capable of taking over the stress. Then most significant thing I am telling now, most persons who have got mental health impact, psychological suffering, they neither report nor seek treatment. And when you try to reach, many of them will resent intervention, reject your intervention, and even resist it. This is because of the internal stigma factor, double stigma. Stigma of the disease, stigma of the suffering, then why to have a stigma of a branding or stigmatization due to as a recipient of psychological help. So in all the surveys, this factor is an impediment in correct assessment, but still people help. Lastly, what is called the PFA, psychological first aid. The components, there are a number of schools, because once this World Trade Center disaster came, in a very active way, aggressive way, I would say, these mental health professions jumped into the arena. And Johns Hopkins came with a first PFA module. Then American Psychiatric Association, APA. Then the second APA, that is American Psychologists Association. Then WHO. A number of agencies, they came with a PFA, modules of PFA. But by and large, I just sort of sorted out, harvested these things. Few things are common. One is, first, when a person has a mental health impact, make him safe, make him stable. Give him an off, duty off. Give him some stability in his circumstance. Give him a reprieve from his work stress. Give him rest. Give him a factual reassurance. That is the first step. The second is, you have to give him comfort. Comfort in terms of the rest, food, good food, the exercise. Exercise has a stabilizing effect on most of the emotional and mental health problems. This has been established, not by way of a general well-being, but a specific effect on the neurotransmitter systems with the endorphin release. Exercise is identified as #1 mental health stabilizer. Then various recreation, give him comfort. Then various relaxation techniques have been recommended, and including yoga. Then of late we hear so much about what is called the mindfulness. Then CBT principles, cognitive behavior therapy principles can be used. So relaxation and this type of inputs can be given. So safety, comfort, and now connect. What is connect? Most important connect is connect to the correct information. The direct sources, reliable sources, and optimum, right, reliable information. And it should be optimum. And social media exposure has been identified as one factor which adds on to the mental health impact. How to fix sign, it can be there, but it has to be regulated. Then contact with the family. But you know, the COVID time, many of them are not able to go to their family. And even when they go, they can see their child, infants, children, toddlers through a glass window. So contact has got there is a digital or a technological interface. But even then, try to have an interactive contact with the family. Then with friends, supporting, stabilizing friends, you identify. Then there is a term which may not be liked by the most of the present generation, mentor or guru. Many people don't like these terms. But what is meant is people who can give some sort of inputs towards stabilization, drawn from their experience, but I would say more drawn from their internal resource. We psychiatrists or psychologists, we speak of what is called the natural therapeutic person. In any society, any community, any village, any city, you would find people who have got a natural therapeutic approach. They give consolation, they give solace. It may not be a big, in terms of big scientific modules, but natural therapeutic people. Such people I call the mentors or gurus. So these are the components of this. Then other components, they are more like work and environment engineering, I would call it. Work environment or engineering environment. Then work schedules and work breaks and work bridges. A stressed person, if he can way of bridging with another person who is more stable in the workstation, that can make sort of changes. Then optimum protection and communication in the workstation and support. This is some of the things which can be brought in the workstation. Then coping strategies, how to cope. Actually, COVID, this is a novel situation. The virus is called novel, and the management also is novel. It cannot be compared with the previous stresses. But still, if you have an experience of handling a stress before, in the past, that can be drawn into the present situation. These are the ways in which we do the psychological first aid. Then recreation, discourage maladaptive coping strategies. That is boozing and drugging, boozing and doping, not to be there. Discourage. Then lastly, road to resilience. Resilience, what is resilience? Resilience is the ability to resolve a problem to your advantage. There's a term which is going around, altruism. How to cope with it, develop altruism. So I would say it's a too tall a term. It may not be that easy to imbibe it or to, but at least work-related stress, I would accept. You know, one simple rule or one thing which can be said is, try to help another person. And when you help a person, there's a very interesting physics in human emotions. When you take the problem of another person, the worry of another person, burden of another person, your burden comes down. This happens only in the mind, not in real physics. If you take additional burden, your burden gets more. But in human relationship, if you take the burden of another person, you will find that after some time, your mental burden comes down. These are some of the things which are included in the PFA, that is the psychological first aid, which are the main tenets through which we help people with mental health impact. And I look forward to really Dr. Rajalakshmi's data, because she has communicated, because there's about close to about 50% of people who have some sort of impact, but not very severe enough. That is a small minority. We look forward to inquire into this population with a structured interview schedules, so that from the KIMS fraternity itself, we can come with substantial, solid, robust sort of observations as far as the healthcare burden in these disaster times. Summing up, I have been giving a history of disaster medicine. I also mentioned about the epidemic care, epidemic medicine, as so to say, and the mental health impact, how it is so often seen, the ecological factors as well as the profile. I mentioned the 5 things: emotional, cognitive, major syndromes, behavioral, and even disruptive, escalated problems. Then SAR study, I just gave an outline. And just some preliminary data Rajalakshmi has suggested, though the slides did not come.
She's
I've shared that.
she's online. If I'll hand it over to Dr. Rajalakshmi. I think one of the things to keep in mind is that there's a saying that doctors make the worst patients. And I think one of the challenges when it comes to healthcare workers, and especially mental health in healthcare workers, is there is a reluctance on our part to seek help from our colleagues, and usually manifests when things become extreme. So I think, one of the points that you brought up is that don't be afraid to ask for help, regardless of what your situation may be. Don't hesitate to reach out. So thank you, Dr. Kumar. And
thank you.
Dr. Rajalakshmi, I think we can go back on to the questionnaire.
Yeah. So let me start sharing this questionnaire. So first I will be presenting some data on how the doctors have responded. Can I have the first slide, please? Yeah. So the first question that was put for them was, rate your COVID-19 fear factor. So as you can see, moderate fear, 73% had moderate fear, and at least 5 to 10% had mortal fear. So that that I think needs attention. So quite a good number, around 83%, I should say, 80% at least had some form of fear factor associated with COVID. Can I have the next slide? The next question that was put forward, do you feel you are an asymptomatic carrier of COVID-19? Because many felt that probably they were already infected and probably part of herd immunity and so on. But when we directed this questionnaire, we found that at least 60% felt that they are not a carrier, and majority don't know. Only 11% felt that probably they're already a carrier. Can I have the next slide? Can I have the next slide, please? Yeah. Have you ever been, who have felt any inadequate supply in the area where you have worked, that is COVID area, fewer clinic, ICU, ER, and isolation? I have put this question because the commonest fear factor that I feel, at least from when I converse with residents and so on, is that everything is associated with PPE. Some may be real, some may be perceptional. So this is what the response is. In the last 1 month, whoever has posted, they have responded, and I think 57%, a good number, were not posted in the COVID-19 area. So focusing on the rest, I think 23% is not applicable. 57% is a good number. They felt that they didn't have any problem with PPE, and around 5% they felt that they had occasionally, and 14% had frequently. But this is only 21 response, and when I looked at, only 3 people in that come under the 14%, and they have issues with the length of the gown and so on. So actually this is a real concern. But if I give a good feedback about PP, I think 50% of their concern will be corrected. That's what I gather from whenever I communicate with them. So can I have the next slide? Previous one. Yeah. Was the deficiency attended to? Yes, majority have responded yes in 60%, up to 60%, not applicable in 23% because they were not posted, but they have attempted that question. 20% comes to 3%, and they are worried, but because of their gown issues, and those things can be really solved, I feel. Can I have the next question? In your opinion, how prepared are we as a hospital for COVID-19? There was 70 response. As you can see, around more than 85% have responded that we are prepared in the, and around 10% still feel that we are not as prepared as we need to be. Can I have the next question? In the order of grading, how well are you prepared? That is specifically pointing to that person who is attempting to work in the COVID area. So 10% have responded they are not prepared, and majority, around I should say 65% or so, have responded that they are prepared, but a good number they say they are not prepared. I don't know whether they are surgical team or so. I have not split up the data, but this is an interesting fact. Can I have the next slide? How well will you describe your psychological impact of COVID has on you? If you look at the response, so anxiety and insecurity were the commonest impact that they have mentioned. Anxiety and insecurity. If you look at depression, that is not a major impact that they have put forward. And for 11% didn't have any impact on them. And the rest is all split to 1 or 2 answers. These are responses. These are fear of getting infected, uncertainty preying on the mind, conscious about surrounding, just waiting, fingers crossed. Can I have the next slide? Universal, I'm splitting the rest of the responses. Universal precautions, insecure about giving it to community and family if at all I contracted, financial, aggravated OCD, neutral stance. So these were the split response, but the majority of them have responded as either anxiety or insecurity. Can I have the next slide? What is the designation? Because we want to know whether how many were a consultant and how many were registrar or resident. 55% were consultant, and rest were either registrars or medical officers. Okay, so these were the responses from the doctors. And can I have the next slide? Yeah, now I will come to the nursing department responses. There were good number of responses, 439 response. If you look at their response, the rating of their COVID-19 fear factor, moderate fear in 47.6% of respondents, and mortal fear is a good number. I should say around 12, around 10% or so. Yeah, or little less than that. Yeah. Next question, next slide, please. Do you feel you are an asymptomatic carrier of COVID-19? Majority feels that they are not carriers. 20% up to 20% feel that they are. Okay, next question, next slide. Do you assume that every patient you see has COVID-19? 70% responded as no. 30% have responded as yes. Next slide, please. Again, the similar question which we have put forward to doctors, the same question to nurses. Have you worked in an identified COVID area in your hospital or involved in the management? Around 50% have worked, 50% have said no, they are not posted in the COVID area. Okay, next slide. Okay, so have you ever have you ever felt that your PPE was inadequate when you have worked in the COVID area? The same question that I have put for doctors. Here's a response. 47% have not worked. The rest, 47% they have not found any inadequacy in procuring or gaps in the PPE procurement, and they are happy. And the majority, if they have found one, they have found only occasional problems in getting some PPE, and very minimal who has responded. Yes, I should say it is around 2 or few percentage, minimal. Can I have the next slide? So again, among the nurses, in your opinion, how prepared are we as a hospital for COVID-19? You look at that response. Around more than 96% have responded that we have prepared well. Next slide, please. In order of grading, how well are you prepared to work in COVID area? Only 1.6% of the nurses were they have responded that they are not well prepared to work in COVID area. But majority have responded that they are prepared to work in COVID area. Next slide. Yeah, this is the psychological impact. If you look at the split of responses, again, anxiety, none is 45%, that's a majority again. Anxiety and insecurity, these are the commonest responses that they have made, anxiety and insecurity. Among the rest of the psychological impact that they had was they were concerned about the contact, facing with positive mind. I have a 7-month-old baby. Next slide, please. Be good. I can recover easily if I get good support. We shall overcome. Loneliness. Next slide. Okay. So looking at the nurses' response, I think majority are in a good mindset. Few are concerned and anxious as well. So this is what I gather, and probably we can definitely work upon it and address. And there is there may be, as I said, there may be few may be real concerns and few may be perception, which we'll have to ask individually and we'll have to address to that. Others. Yes. But again, I feel that it is a good effort from all of us preparing this hospital for the pandemic. And I I feel with all the cooperation from all the department, we have done to our best. And there may be gaps which will definitely will improve. And but I don't feel there are any major gaps. I'm open for questions and answers.
Okay, thank you, Dr. Rajalakshmi, and once again, thank you, Dr. Kumar, for that informative session and a survey of our staff and their impressions on our preparedness. I think clearly the uncertainty is a huge aspect of it, and that uncertainty leading to anxiety is what we're most commonly seeing. So with the remainder of our time, I'd like to open it up to questions. The questions have been submitted online through the chat. One thing I'll mention is we're only taking questions from the audience for people who have signed in with their name. There are a few people who have put numeric things for their ID, and we're not going to be accepting questions from them. I will now turn it over to Dr. Pramila and the team in Trivandrum who have reviewed the questions and will present the questions to both Dr. Kumar and Dr. Rajalakshmi. I would have just asked that if you could just read out the question and if it's intended for one speaker, then we'll allow that speaker to respond, and then the other one can also add to that. Dr. Pramila? The conference room in Trivandrum is on mute.
To put the question forward to Sir.
The question is from Dr. Prakash from Kollam.
Yeah.
This question is whether OCD patients needs a higher dose through teleconsult during this time. And one more question. In your clinical experience, the social distance which has been needed at present situation will worsen their symptoms.
Yeah, the question is a specific question related to obsessive compulsive disorder patients. And the answer is, this is a situation, the social distancing as such is a extremely unfamiliar situation, and obsessive patients are generally known to be more inflexible, more rigid, more stubborn. So when things change from what it has been, their experience, there can be a temporary feeling of anxiety and all. But I would, at the same time, they have a perfectionistic element also in them. So they would try to adjust. They would try to adjust to the situation. Now coming to the third aspect is, many of the obsessive compulsive symptoms may have themes like contamination and contact contamination and things like that. Many of them, at least a segment of them, may feel better when social distancing and tactile sort of a distancing increases, they may be happy. Now coming to the second part of the question, that is whether OCD patients need a higher dose through teleconsultation. It is not, if the symptoms are there, symptoms are definitely escalated. And after a reasonable period, the symptoms persist, causing substantial distress, additional distress, then we may increase it and manage to some reasonable limits, like increase the dose to 10% higher up. But you need not automatically increase or give an additional umbrella of medicines just because there is a social distancing for the obsessive patients. I would go by the patient-to-patient basis, depending on the escalation of symptoms. That would be, even in teleconsultation, the dose is determined by the increment in the symptomatology and additional suffering. That would be the variable on which dose escalation or dose modification would be pitched. So that is my response to it. Thank you.
Thank you, Dr. Kumar. If we could have the next question, please.
Yeah, this is from just one second. This is from Dr. Vishwajit Bora. Thank you, Dr. Kumar, for the presentation. How important are group-based activities in promoting morale and bridging knowledge gaps? How important are group-based activities in promoting morale and bridging knowledge gaps?
Yeah, certainly, because you are coming to this specifics anywhere. In a general way, I would say, whenever there's a group format for sharing information, that would be a big asset. Anywhere, any professional forums, any learning platforms, learning situations, a group activity is welcome. But coming to the specific situation of COVID, this novel virus, as I said, this is a management involves so many things which are unfamiliar, uncertain. And if there's a forum for sharing the experiences, sharing the information, sharing the wisdom, certainly that will add. I would say that any of these epidemic management settings, there should be a slot, a group sharing slot, where information is shared, the scientific knowledge is shared, the day-to-day experience is shared, the attitudes and the impact, personal experiences are shared, and even suggestions for recovery are shared. I am for it. The group activities are definitely welcome in such stressful, unaccustomed, unfamiliar clinical situations.
Okay, Dr.
Thank you. I
Srijit.
think, group activities are important, but we must also remember, depending on how we do those group activities, to maintain social distancing within those activities. All right. So next question, please.
Okay, Dr. Srijit Srikumar has raised his hand, so he can ask the question.
I think it would be best if the questions can be written in the chat and asked by the team in Trivandrum. So Dr. Sri, that's a question. He can write it in the chat. We'll come back to him. If we could go on to the next question, please.
So next question, any special treatment plan for xenophobia?
No, xenophobia as it is defined, it is the fear of the unknown. The first aspect of helping a xenophobic is to reduce his sense of unfamiliarity of the phobic situation. The phobic situation has to be presented in an understandable, reasonable way to him. The best, as far as this situation is concerned, xenophobia about COVID, if you ask me, is to give a factual, scientific information from reliable sources. That would be the first step. So presenting factual data, and secondly, the management lessons, if it can be called out and it can be crystallized and presented. So that would be another. Third is what we use in any phobia is you just sort of your experience of handling that situation, what we call as modeling. Suppose I am more familiar in handling COVID. Let the other person who has a problem, let him be with me. I escort him. That type of what we call as modeling in psychotherapy. That is a modeling is you model yourself on the experience, on the pace of another person who has a little more experience. Not like one person has the total wisdom, another one is totally blank. But if you have a slightly more experience, I offer to give him to be a model for him. So xenophobia, these are the principles in which a xenophobic can be helped.
Okay, thank you, sir, for that. Now, this is another question from Brahmara Madhuri. This is to Rajalakshmi as well as Kumar, sir. First question is to Rajalakshmi. What are the target group who took the questionnaire? She just wants to know who are the target group who took the questionnaire.
I shared my slide. Doctors of all consultants as well as registrars and residents. And among nurses, I included all the cadres, like from nursing staff, students to the supervisors and in charges and managers. So it was directed, but then we had captured what designation they had, they held, and so that we can understand in a better way.
Okay,
I think,
thank you.
Dr. Brahmara, to answer your question, the survey was done in India and the Indian hospitals. The survey has not been extended yet to the Middle East facilities.
Okay.
Yeah, one more question from her to Dr. Kumar.
Yes.
How are children and adolescents affected by lack of regular schooling and the pandemic, and in general, how are children and adolescents affected? It's a very interesting question from my side also.
Yeah. I think it's because the problem is, as far as our place is concerned, many of these children, especially the the lower classes, their exams are over, completed or partly completed, and so they got a the vacation, a preponed vacation. But then many of them had plans to go out, a little bit of travel. All these things have been totally sealed. And actually, in many households, these children are becoming a real militant groups because they don't have a way of going out. And I know at least 2 to 3 dozen parents who are fed up with this situation because they had some sort of group activities, some summer camps, some summer activities. All this has been stopped, and we make them sit, and they are really affected a lot. But then we have no option but at this period of time. So we give them some sort of alternate engagements. It works to some extent, but it doesn't work also, because I would suggest that this is a time for parents to really take their training in communication and training in spending time with their children and training in listening to them. And these are some of the ways. Then of course the other occupations like a little bit of handicraft, little bit of painting and all. Because I have a 8-year-old grandson. I said I will prepare a skit for him to act and things like that. He likes acting. Then he said, no, I want a real script. Means he want a film script to act, not something which the old man scripts for him. So they are difficult people, but they are very, very stimulating people also. It's a challenging time. And I wish our parents, they make use of this time to empower themselves.
So next question is from Dr. Anjad. How to deal with staff with claustrophobia regarding full PPE?
Claustrophobia?
When they're wearing full personal protective.
Yeah, this can be a very difficult situation because claustrophobia, but within that, even people without claustrophobia, many of them, in fact, I was in contact with people in the front line of COVID fight because I have very dear family members also doing the same task elsewhere. And I have a number of friends in Mumbai who are in the COVID front. So many of them are describing to me because this PPE thing, that especially that hazmat suit, that hazard gowns and things like that, that gives a real feeling of suffocation. But that is different from claustrophobia. Claustrophobia is the person feels that this fear should not be there. The other one is a factual, the realistic type of a suffering or suffocation. So claustrophobia is something where he feels I should not be having it and I am having it. But still, there can be an overlap. There can be what can be called an overlap syndrome. A claustrophobic person. This is in our term, it says it is just like a person who has been hit by a lightning, got bitten by a snake also, a double hazard, The idi vettiyavana paambu kadikkunnu. This is in vernacular, but that is the somebody who was hit by a lightning gets bitten by a snake. That is the situation, claustrophobic on this gown. But if you just analyze the symptom, claustrophobic person excludes himself and his apparel from the claustrophobic stimulus, only external environment. So this, I admit that there's a higher suffering for the claustrophobic in the PPE suit, but that percentage of this double suffering individuals will be much less. And we can desensitize him by some sort of stimulus, give half a suit first and give a suit for half an hour first. Like that we can desensitize, but when it doesn't work, the best thing is to make him leave that PPE and start doing other things for the COVID patients. That would be.
Thank you very much, sir. Before going to next question, I'd like members just to come out with more questions regarding any concerns, especially our doctors regarding any concerns on the use of PPE, availability, any concerns will be taken up. I'll go to the next question. This is Dr. Kumar again. This is from Dr. Abubakar. Do doctors and healthcare providers need to seek psychosocial professional help and guidance during this pandemic? Should they go and seek the help?
Yeah, there are two ways of addressing the question. Before you set on this particular task itself, or in the early stage, before you feel any distress or any distressful symptoms, whether you have to seek it. That is what is called as the psychological immunization. I mentioned that, but that if you just ask me as a clinician, I would not recommend, because basically our assumption is everybody has got certain degree of, but when you feel the signs of distress, please make it a point to communicate at least with your peer group. And if you have a supervisor who is understanding and accepting, that is a place where you can communicate. But if the situation does not sort of gets settled or diluted or sort of attenuated, at that point of time, definitely it would be a point, because I mentioned this, many of them, they do not report and they do not seek, which is not because it has been shown that people who seek help first, if you are able to overcome that, that reluctance, that internal stigma, that can be a very positive thing for a person working in a setup. This is my feel about it.
Thank you very much, sir. Dr. Sharif, these were the questions which we got, and a lot of appreciation from all around. Thank you very much.
Yeah, I think there were a few comments that I saw on the chat, and I will rephrase it in the form of a question. The one was from Dr. Brahmara regarding therapies such as yoga and meditation and the role in this type of situation.
Shall I? Yeah.
Please go ahead.
So I would be very positive about this particular thing. Any type of relaxation practice. What the relaxation, when I say, it is not just like I will take 3 pegs and relax. No, that type, not that one. The systematic muscular relaxation with the breathing exercise, the combination of breathing exercise with systematic muscular relaxation, that can be helpful. And what we call as the Jacobson's relaxation in the Western technique. Then we have yoga, but unfortunately there are umpteen schools of yoga. One yoga school doesn't like the other yoga. That is a different thing. But what I have found is a systematic muscular exercise, muscular relaxation plus breathing, that can be very helpful in reducing the general level of arousal, general level of anxiety propensity. And that can be in fact, I would even suggest, go to the extent that anyone who works in high intense medical settings, especially in the times of this epidemic disaster, they should be positively encouraged to do systematic exercise and the relaxation. And if yoga can be, and it's a very good thing. So rather than pure meditation, I would recommend a relaxation exercise with a component of muscular exercise, breathing exercise, and maybe a little bit of meditation. That would be, I am positive for these type of techniques, and I would even say that it has to be there as a general practice among the high intensity medical people.
Thank you, sir. One more question from Kim's.
I'd like to just, I'll just share a quick thought and then I'll ask your question. I just want to share a personal story with you. A very, very close friend of mine is an American. He was the best man at my wedding a couple of weeks ago. He reached out to me and he sent me a message that really brought me to tears, and because he's in the heart of things and fighting COVID, and he wrote to me saying that in case something happens to me, my family will be fine financially, but you've been a very close friend, and I would ask you to look in on my family every once in a while to make sure that they're okay. And literally, it brought me to tears, and I could feel his anxiety. And it caused a lot of anxiety for me as well, and I'm still emotional when I talk about that interaction. But I think one of the clear things that you've put forth is regarding communication. And I think it's important for us to communicate on all levels, whether it's from an organization to the doctors and to the staff, or within the peer group with each other. I think that helps to alleviate a lot of stress. So I have been in regular communication with my friend so that he has at least an avenue to release some of that stress, someone who's in a different situation perhaps than he is. So I think communication is something that we all need to be clear about in this time, and how can we come together as a community, as a fraternity of healthcare providers and support each other. Sorry, Dr. Premila, you said there was another question?
Yes, this is from Kim's Kottayam team. They're asking sir to explain to them how can they minimize the anxiety and stress level in their patients.
In the patients.
Yeah.
So this is I would say, this is a source of, I would say, distress for many caregivers in the present situation, because when their subjects themselves, they ask for some sort of factual explanation, some sort of assuaging of their insecurity. They don't have any competence, because this is a situation because we do not know many things about it. But there, the best thing is you communicate. These are the things known about our disease. But so far, the specific inquiries are there. Try to answer it in a way, in a factual way, in a non-threatening format. This is the maximum we can do. But what most important is not to give. See, there are two things people don't like, people detest. One is giving advice, taking advice, and secondly, bland reassurance. No, you will be all right. By tomorrow morning, everything is fine. This type of bland reassurance, immediately it is rejected, it is resented. And next time when you are about to give it, they say, no, adu parayandan worry. They don't want it. That type of bland reassurance is not what is required. At the same time, factually, you can explain some of the things. And even I would even say, these are the things not known. But as soon as we are able to get an idea, we will tell you. And in fact, I interacted with some, even that Kottayam the physicians who are involved in looking after that elderly couple, 93-year-old man and 88-year-old lady, you know, they got well and they discharged. And they said that the problem is they were looking after, but both of them have not seen the doctor's face. Doctor is with that N95, this mask and all these gadgets. So only after they are cured and discharged, they saw this human being. So is there any way of keeping this, you know, of course, these are all very sensitive situations, but at least a real life type of exposure with without this type of masking and masquerading, whether it can be provided. Because one thing which people find it difficult is this anonymity of responses, and you know, the responses come from somebody, but you are not able to figure out whether it is looks like a you know, cucumber or lady finger. You are not able to decide, you know. So these are the things. What happens is lot of our clinical interaction has this is derived from our face-to-face contact. This is deprived very often in intensive care. There has been an extremely rich deliberations on this, and now it is much more with this COVID. So these are the inbuilt problems in the system. The best way is to compensate, as Dr. Sharif has said, he has mentioned about the communication part of it. So when it comes to your doctor to the client also, try to say that, see, I am not able to sort of I am listening to you, I am I am understanding, and let us, as things improve, we will discuss it further. You know, that type of a ongoing, you know, some sort of hope, as well as some factual information. That is a sort of a mix which can be given. And but as I would say, one of the biggest handicap for a clinician would be not being able to answer a question, a very relevant question, I would say even an existential question, when a patient poses. This is there in different facets of medicine, much more here. I think by a sort of open communication and face the communication and pauses in communication, this has to be, and that is the dynamics of, because doctor-patient communication, as in other settings, do not carry well in this setting. It is a challenge, but it's a challenge which can be met with the dedication and commitment. This is how I would like to answer that.
Thank you, sir.
Thank you. I think we're approaching an hour and a half of the session right now. I would just like to ask the speakers if they would like to make one or two just sentence closing remarks from either Dr. Kumar or Dr. Rajalakshmi, and then we can wrap up the session with a few words from Dr. Sahadullah.
Yeah. So from my side, I want to reassure our healthcare worker that they'll be protected by all means at all times whenever they are in the COVID area, because that is our foremost important. So they should be assured that no mishaps will happen and we'll take utmost precaution, but they have to be empowered with proper donning and doffing and to know what to wear when. And then I think I can at any time will be available to solve any of the concerns regarding PPE or any of the concerns like insecurity or whatever they have, anxiety or whatever they have come across. I am open for communication and contact at any time, and I can do whatever help that I can do and direct themselves where they have to attend to and so on. So I'm open, so you can feel free to contact me, and thank you again.
Thank you. Dr. Kumar, any closing words?
Yeah, I would, you know, the most important is this particular session has brought in a number of issues. In fact, the participants, the way in which the questions have come, that shows that the concern, and many of them are well considered questions, and many of them needs a dialogue rather than just summing up or summary statements. What I would like to say is, because what KAP survey has brought, that needs to be vetted with acceptable scientific instruments, because I already indicated to Rajalakshmi that if we would the time and the arrangements willing are available, we would like to have a little more closer look at the different facets, because under the different headings of this mental health impact. Secondly, we would even like to have a follow-up, like 3 months or 6 months or 1 year follow-up of these, because majority of them are going to improve. And the last most important thing I would say is, Dr. Sharif has mentioned about the communication. And as professional colleagues, as professional participants, and even at a level where the professional guides, there should be a sort of communication. Communication not just in intellectual sense, but in emotional sense, because there should be a confidence in sharing information as related to work-related emotional impact. And every institution, every medical setting has to have it. But the COVID time has taught us many lessons. One of the lessons it has brought is, you isolated, you cannot do many things, but together we can probably do much. We support each other. Of course, social distancing is there, but contacts are possible without risking the viral load or viral onslaught. So the COVID gives us an opportunity to get closer. I mean, as professional colleagues, let that be the take-home message from this particular thing. Thank you. Thank you.
Thank you, Dr. Kumar. I know that one of the things that causes me great anxiety during this time is actually WhatsApp. And I feel that my phone at times is having a seizure with all the WhatsApp messages. And so I've intentionally blocked group messages notifications because, I feel compelled to look at it as soon as I get a message. And since I blocked all the group messaging notifications, I think I've been a little bit more at peace with myself with all these messages that come through. There's a lot of information that at times misinformation as well. And that's why as a group, we've also created a website to verify information, KIMSCoronaCare.com sorry, can you hear me? KIMSCoronaCare.com to house all these guidelines that have been verified. So with that, I also want to thank Dr. Kumar and Dr. Rajalakshmi for taking the time to conduct this webinar, as well as Dr. Pramila, the IT team at KIMS Trivandrum, for conducting this and the question and answer session. And to all of you who have joined from all of our units across GCC and the Middle East. I think one of the things that clearly I'm seeing on the chat boxes is that we should conduct more webinars. And so that's one thing that we will look at doing over the next couple of weeks, is conducting more sessions and for both doctors and other staff who can participate in this. So thank you, everyone. And we will close with some remarks from our chairman.
Shari, that was, thank you. And that was excellent, well conducted. And our IT team also, even though there were some difficulties. And Dr. Kumar, Dr. Rajalakshmi, Dr. Pramila, Sunil, everyone. I think I want to really thank you. Couple of words, I feel that I attended a couple of webinars on psychological impact before, and I think I would definitely say that ours was today was one of the best one in out of the three, out of the third one I'm attending. The second thing I would like to stress upon is that as an organization, we always try to communicate with our members of the staff, and because we trust them and we depend on them, and certainly vice versa also. So the relationship we have established over the years, and it is a very strong one, and therefore we always remain connected. And remaining connected is the most important thing in all these difficult situations. Want to reassure everyone of that, whatever may come, we have to overcome these difficulties. And as they say, the dark cloud has to pass on, and it will do that. And the important thing, as Dr. Kumar said, yes, there is physical distancing. There should be a social, psychological distancing that is not yet prescribed by anyone. So let us keep connected by the psychological, relationship, and also continue to communicate through various webinars and things. And we have organized a few, and but perhaps GCC was not a couple of those within, but included, but not. But Sharifa, we will organize more in this respect. And that's all I have to say. Thank you very much. And those who are going for Ramadan Mubarak, and in a couple of days. But please remember, the distancing is important, at least physically, and crowding and iftar, all that had been, I was told that government of Bahrain, the Kingdom of Bahrain, that we should not have iftar and most prayers, etc. So follow that all, and as a let us look at all the quality parameters to fight this this epidemic, and we will fight it together. Thank you.
Thank you, everyone, for joining us today, and we hope to see you on our future webinars.